Welcome to The Kick, your expert-led podcast helping you explore and learn everything about getting pregnant, pregnancy, birth and becoming a parent.
On the podcast and our online pregnancy program, Grow My Baby, we share my experience of helping more than 4,000 babies to be born.
And our experience of running a women's health clinic and parenting 4 boys.
We're here to help everyone to feel empowered in pregnancy and birth with real-life practical information.
Well, welcome everyone. I'm Brigid Maloney.
And I'm obstetrician Dr. Patrick Maloney.
And we've got a Q&A today, Pat.
Good.
Yes, we got some ripper questions in. So, I keep saying as we do, we just get stuck straight into it,
Good.
all right?
Let's go.
Hello, Brigid and Dr. Pat. Thank you for your wonderful podcast. I'm Belinda. I'm 33 from Sydney, and I first started listening in 2021 when I was pregnant with my son. I'm currently pregnant again, 22 weeks and due in August with my second son. I'm calling in today to see if you have any information on how my previous breast cancer treatment may impact pregnancy and labour this time around. As a few months after weaning my 16-month-old in 2023, I was diagnosed with stage 2 ductal breast cancer. I had a lumpectomy, followed by chemotherapy, then radiation, and 2 years of hormone-blocking medication. My obstetrician, who's amazing, helped us fall pregnant via ovulation induction, and he's arranged a baseline echocardiogram due to the level of chemotherapy I received. I was wondering if you had any insights on potential impacts of these treatments on pregnancy, labour, or postpartum recovery, and whether any additional monitoring or precautions are typically recommended for someone in my situation. Thank you so much for your time. Bye.
Some callers are brave, aren't they?
Amazing.
I'd just be a puddle on the floor, I
know,
think.
and I love how she just tells us that whole story.
I know.
This happens to everybody.
This happens. Now
Yeah.
what? What can I do?
Oh, my God. Yeah. So well done. How wonderful for you that you have not only been successfully treated for that initial illness, but that you are pregnant again. So that's fantastic. This is obviously an unusual situation. Give or take, our peak cancer years are much later than our peak baby years. And so we don't often treat people for pregnancies who've had previous chemotherapy, but certainly there are some. So the conditions can be breast cancer. Obviously, that can happen to young women. Less common, but it can. And then there's lots of other cancers like blood cancers, like lymphoma, that can happen to young people, and of course testicular cancer in men. So those have happened to young people in the pre-fertile times, in the pre-pregnancy years, and potentially affecting fertility. The treatment that this woman probably needs now is probably reasonably straightforward. She's had an echo, which seems a good idea to make sure that the chemo hadn't affected cardiac function, which would be quite relevant with the demands of the second half of the pregnancy on the heart rate and the what's called stroke volume, how much your heart pumps out per beat. Is
that a known problem, that chemo can impact your heart?
Yes, so that's why they've checked that.
Yeah.
And then you want to make sure that if you're going for another vaginal birth, that the body will be safe for the big demands on your cardiovascular system that you might experience in labour. And so they've done that. And with the obstetrician checking those things, and perhaps in conjunction with the oncologist to say, well, what exactly did this woman have? What are the known side effects of that medication? Then you could easily put together a plan to think that through. And that could be done on a per case basis. And it sounds like that's already been done very capably for this caller. There are 2 other things that I think are worthy of mention. One is mental health. So this is a big deal. But breast cancer, now pregnant again, and I think that I would be encouraging this person to make a plan for their own mental health, and there are supports available through cancer networks. There are supports available through good obstetric care. There are psychologists and psychiatrists in the community, and I think that I would be trying to help this woman manage her mental health as prospectively and preventatively as possible.
Because it sounds like, I can totally empathise with how she's proceeding, which is, just from that one call, it's sort of facts and things sink in differently, at different times, and, you never know when that's going to, she might say, oh gosh, my mental health's fantastic. But it does pay to sort of have a think about it and have somebody else sort of reflect back to you what you're saying. And,
and if we think our mental health's really good, there's nothing quite like throwing a baby in there to test that out.
Yeah, sleep deprivation.
Yeah. So I would be making a plan for that. And the other thing I thought I'd mention is that some of these cancers that affect young people, especially if it happens before their first baby, there are services around for emergency fertility preservation that can be done before the chemo is given. So if we've got a young woman who's got breast cancer, for example, then before that first lot of chemo is given, even if they're not in a relationship, even if they're very young, they can be offered emergency appointments for fertility preservation, typically an IVF cycle and egg freezing, or if they've got a partner or embryo freezing, and then you go off and have the chemo and everything, and then if that chemo has a significant impact on your ovarian function, then it's less of a drama if you've got some frozen eggs or embryos. Yeah.
Sounded like she had ovulation induction.
Yes, but it's not clear whether that was because of the chemo or not.
Yeah.
Yeah, I suspect not. That might have been a pre-existing
reason,
problem related to causing an ovulation. Yeah.
And maybe we could also put a tip in about breast checks. So your breasts are changing so much after pregnancy and during pregnancy that it's hard actually to be able to detect lumps and bumps in the first place.
Yes, I've diagnosed a couple of cases of breast cancer in lactating women, and they've thought that it was just lactational changes. But when I've examined them, to me it wasn't. Yeah.
Is it routine? Who's checking women's breasts at that
stage?
I
think that self-checks are a good idea, and the lactational tissue should at least feel roughly the same in each breast. And if one's clearly different to the other, that should be checked out, and then off to the family doctor for some imaging. And ultrasound can be used if a mammogram is not suitable.
Yeah.
So if you're actually breastfeeding and all that breast tissue is full of milk, then ultrasound can be better than X-ray mammography.
Certainly less painful, wouldn't it be?
Well, yeah. So there's tons we can do to help, but we want people to have things checked out.
Yeah. So I hope everybody is checking their boobs. Good. Basically. Good. All right. Well, good luck with your pregnancy and your birth, and I hope everything goes super well for you.
I'm Kate Langbrook and I host No Filter. Celeste Barber.
Hi.
Welcome to No Filter.
It's nice to be here.
Yeah, today we're diving into the world of G-Flip.
And your voice has always been such a calming, warm energy. So that's why I tear up, because you're always growing up with you around. So thank you.
Sally Hepworth, what a absolute jewel you are in the crown of artists.
Oh, thank you. This has been lovely.
Today, we're talking to Rosie O'Donnell.
I just want to tell you, this is one of the best interviews I've ever had.
If you love conversations that go deep and stories that stay with you, listen to No Filter. New episodes of No Filter drop every Monday, wherever you get your podcasts.
All right, Dr. Pat, let's listen to this one.
Hi, Dr. Pat and Brigid. Just a quick question. I found out that I was having an ectopic pregnancy middle of April this year. The whole lead up to this pregnancy, I was taking the multivitamins, the folate, and because of the methotrexate injection that I received, I can no longer be on those multivitamins until 3 months post-injection. Just wondering when about I can restart those vitamins. Thank you.
All right, Patty, maybe we could start first with
What's methotrexate?
What's methotrexate?
Yeah. So if someone's got an ectopic pregnancy, a pregnancy that's in the wrong place, it's stuck in the cervix, in a Caesar scar, or in the tubes, most commonly the tubes, then traditionally the treatments were surgical. But if it's small and unruptured, and found on an ultrasound, then it can be treated with a medication called methotrexate. And methotrexate is probably best thought of as like a chemotherapy type drug. It interferes with folate metabolism and stops the pregnancy from growing. It causes it to miscarry and hopefully resolve without surgery. And it's suitable for small, unruptured ectopics where the woman is safe, feels fine, but the diagnosis on ultrasound is really clear. If you're going to use methotrexate, you give it as an injection, and then you have to monitor quite carefully that it's working. Because if it's not working properly or quickly enough, then the ectopic pregnancy could continue to grow and then rupture. So there's a whole protocol where you calculate the woman's body surface area. That's like the dose. Give the methotrexate, and then very carefully watch the pregnancy hormone levels until they're back to zero. And because the way methotrexate works, it interferes with the metabolism of folic acid or folate. Then it means that if you're taking folate, then the folate's not going to work very well, and you might be taking that folate to prevent abnormalities in a subsequent baby. And there are actually, it's not just that the folate doesn't work so well, but there's actually some rare interactions with methotrexate that could actually be dangerous. So you're best off stopping that altogether, making sure you don't get pregnant again, right up until whoever's monitoring your ectopic tells you that the pregnancy hormone levels have gone right back to zero and it's safe to commence.
So, I mean, this woman was told 3 months, which is interesting, isn't it?
It might not be as long as that.
Yeah.
Yeah, so let's say, for example, she's monitored over that time and it's clearly gone right back to zero, then they would say, okay, fine, that pregnancy's gone. You can restart your prenatal folate and get pregnant again.
Obviously, we don't know what model of care she's in, but let's say she's in a public unit and the public unit's just gone, for safety's sake, it's going to be 3 months. By then your HCG is going to be normal or zero.
Yeah, they should still be monitoring it.
Right.
So when we the thing in a private practice is that you've got sort of one doctor looking after these things. But in public unit, if anyone's been given methotrexate, then the doctor of the day on that unit will have a little folder to look at, and they'll say, Mrs. Bloggs has had a methotrexate, you need to check her bloods today. And then as a team, they would follow that through to zero.
So if she was super keen to get back on to trying for another baby, could she go before that 3 months and have a blood hormone test at a GP?
No, it should not be done through multiple people.
Yeah.
It should be done through the unit that gave the methotrexate in a protocolized, organised way.
All right.
Yeah, so no one falls through the cracks.
Yeah, so she could go back there and say, look, I'm keener than the 3 months. Can you please check?
Well, potentially, if it went all the way back to zero and they were happy, then yes.
Good. All right. Well, I've got this one, which is going to be a big one, so I think that probably will take us up to the end of our session. So let's have a listen.
Hi, Pat and Brigid. I'm Imogen, and I absolutely love your factual-based podcast based on all things women health and pregnancy. You're part of the movement in creating awareness for all of the complexities associated with, frankly, just being female. So please pat yourself on the back. For a brief history of myself, I'm 24, my BMI is about 23. I've had PCOS and stage 3 endo surgically diagnosed. I've currently got a merino in situ, and my husband and I are starting the journey of trying for a baby soon, partially out of our own desire to do so, and also just the awareness that it probably is going to be a little bit harder given my history, and my mum also required a full hysterectomy at 30 due to severe endometriosis. I recently had a pelvic ultrasound to visualise where my marina is so we could have it removed and start our TTC journey. Endometriosis was visualised again, particularly on my left kidney. I've got 40 plus follicles between both of my ovaries. Adenomyosis was discovered as well as myometrial cysts. While I already knew about endo and PCOS, the addition of the latter two conditions, quite frankly, has left me full of anxiety regarding our chances of conceiving. I should also note that I've got factor V Leiden I inherited from my dad, and I'm aware that heightens my risk of miscarriage. My question essentially lies within what would your steps be when implementing a plan for a couple like this when trying to conceive? Would you allow them to try naturally for a while, or would you potentially escalate them straight to assisted reproductive technology? I feel as though the decision as to when we have a baby has been made for me due to my body somewhat already failing me before I even try for a family. I hope I haven't been too much of a downer. I just feel so lost and afraid. Thank you for taking the time to listen to me, and I hope to hear from you soon. Thank you.
Wow. Thank you for getting in touch. That's, there's an awful lot going on there. I'm sorry to hear that you feel so lost and afraid, and we haven't even sort of started. So there's lots and lots we can do to help. But this is somebody we can hear that you're struggling physically and emotionally with what's been going on.
And at 24, to have such incredible, vast knowledge of herself and her body and the system, and making decisions now because she knows that she might be against the clock or whatever. Amazing.
So there's this person has a burden of all the stuff that's been going on with her, and then kind of the burden of knowledge. She's not just whistling through life going everything will be fine. She's got all this knowledge, and and she's aware of the problems she might have. What we don't have, as far as I can see, is a plan. So we need a plan.
She's better off now knowing all of this than someone who started at 30 thinking, now I want to have my babies.
For sure. For sure. So she's definitely better off, but she may not feel that on a day-to-day basis, and a plan's going to help a lot. So there's a number of things going on, and the first thing I would say is that this is a specialist level problem. The question of whether you should be trying naturally or going straight to assisted reproduction is a complex one, and the things that are going on with you are complex and at a specialist level. So we need reproductive opinions, and we need gynecological opinions and some obstetric planning and so forth. And this is someone that needs a lot of our expertise. So the big issues, there's been significant endometriosis, stage 3 endo. She said diagnosed laparoscopically. I hope it was also treated. So let's assume for a moment it's been treated. It's PCOS apparently, or polycystic ovaries with multiple follicles on each ovary, peripherally located. That brings into question whether we're ovulating. There's a marina that needs to be removed. That's probably the easiest thing. There's what looks like some ultrasound evidence of some residual endometriosis that has not been excised. Adenomyosis of the uterus, where that abnormal glandular tissue is present in the wall of the uterus, not just outside the uterus. And factor V Leiden, which is a procoagulant condition, a inherited genetic situation where you're more likely to get early pregnancy loss and deep venous thrombosis. So plenty of planning needs to be done here. The question at the end of the day from the caller was, should I be trying naturally or should I be having assisted reproduction? The answer to that will actually become pretty clear. But let's say, for argument's sake, the factor V Leiden is just something that's been discovered but hasn't actually caused any problems yet. That will then, in most cases, the question about whether that needs anticoagulation or not would not be one we would worry about until you're actually pregnant. The effect of the residual endometriosis, we won't know about that until you're trying. Okay, so probably the most pressing issue is with those ovaries that have a polycystic appearance on ultrasound. Are you ovulating? That would be the big one. I'd also not like in this situation to find a male factor problem 12 months after we'd been trying with everything else. So a few things I would recommend would be, number one, escalate this problem up to to specialist level.
Can I just say, what do you mean specialist level? What are you thinking about there?
I don't think that this is going to be within the skill set of your family doctor. There's a lot going on here. And I think that this woman should be having a pre-pregnancy assessment from a gynecologist, obstetrician gynecologist now. Yeah. There's too many things that you don't want to find out 12 months later you should have fixed 12 months ago.
Yeah.
Yeah. And I would often say that should be done by an O&G or by a dedicated family doctor, but I think in this case there's so much going on that this would be at a specialist level. And then work out with those ovaries that have an unusual appearance on ultrasound, are we ovulating? And if not, we've got to address that, work out why not, and give some treatment to start ovulating.
And can we just deep dive on that? So that is her having some blood tests?
Yeah.
21-day blood tests, is that right?
Yeah, we don't know much about the cycle, but we could use some ovulation predictor kits as a first thing to see whether they're turning positive, or some day 21 progesterones to see whether we're ovulating. Check male factor, and then set some. Let's assume that you know, I've talked about my simplified model for getting pregnant. We need eggs. So let's say she's been proven to ovulate. We need a safe place for them to get together on your inside. Well, let's say the laparoscopy, despite finding a lot of endometriosis, also showed normal tubes and a normal cavity in the uterus. Well, that gets a tick. And then third, we need sperm. So check the semen analysis. And let's say they all get a tick. Then if the advice is to try naturally for 6 months, just needs a clear cutoff. Yeah, we're going to try for those 6 months because we've got tons of time. We're only 24 years old, but we're not going to try forever unless it just works. So clear cutoff, and then after that clear cutoff is up, reassess. Not pregnant yet. Offer a reproductive opinion now. Yeah. So has the ovulate, let's say we're using a drug like letrozole to make us ovulate, has that worked every time? And yet after 6 months we're still not pregnant? Then the opinion we need now is from a reproductive specialist, as sort of a branch of O&G, where that person might say, right, your best option is more endometriosis surgery. Or your best option is continued ovulation induction, or no, your best option is IVF. Yeah. And that advice these days is surprisingly scientific and surprisingly protocolized. It's almost like you can sort of feed in the patient, is this old, has this problem, and it'll say they should have IVF, or no, they should keep going as they are. Yeah. So reproductive interventions are mature enough and old enough now that they know the best, most sort of evidence-based advice to give individual people.
She said that she was, able to cope with the endometriosis, but the additional diagnosis of adenomyosis and endometrial cysts, has that impacted on her fertility to the degree that she thinks it has?
Well, adenomyosis, is where that abnormal glandular tissue is within the wall, and the worst, or one of the worst forms of adenomyosis is if they can see something called a myometrial cyst, which is within the myometrium, the muscle layer of the uterus, the wall. There are these cystic structures which are big blobs of glandular tissue that shouldn't be there, and that is not necessarily an upfront cause of infertility. Someone might have all of that and still conceive. So in a 24-year-old, we might say, well, let's find out. We've got time. Let's see what 6 months of trying, how that goes. Whereas in a 38-year-old, we might say, well, they might be our best 6 months. Let's not waste them. Let's go to IVF now to make sure we get some good embryos, and then we'll do that. So age is super important. In the 24-year-old, you might say, well, look, that apparent adenomyosis, we don't know that for sure. That's an ultrasound opinion. But let's say that apparent adenomyosis, yes, it's there. In a 24-year-old, it's unlikely to progress to a horrible situation very quickly. And let's see if we can get pregnant without overdoing the intervention.
She doesn't mention it, but some people with this long list of issues also has problems with actually having sex. It's painful and it's
yes,
yeah. So that's another thing that if she hasn't mentioned it in this. That's something that she could be talking to a gynecologist about.
100%, because there's no sense if you tick all those other boxes so that you're going to egg, sperm and a safe place for them to get together, you also need to have the ability to have intercourse at the right time of the month. Yeah. So some people would go to IVF if they couldn't have intercourse. Which, and you might say, we'll have an operation to fix your endometriosis. Well, sometimes we'll operate on the endometriosis, take out all the endo, they've still got pain. So there is a role in some couples for reproductive interventions just based on their inability to effectively have intercourse in the fertile time.
So much for her to think about. And I the looming idea that a mum had a hysterectomy at 30, I suppose, is always ever present.
Yes.
And good on you for starting at 24.
That's one of the reasons why it's good news that she's in a position to try for pregnancy now.
Yeah.
Because I often say, as your gynecologist, it's none of my business when you have your babies, but if I get a vote, I'd go for now rather than later.
Yeah.
So let's say for argument's sake, her mother's hysterectomy was done at the age of 30 for severe endometriosis and severe adenomyosis of the uterus. Well, we got to have babies before that. Yeah.
Yeah. And so this caller might be thinking about how many babies she wants to have too. So this is good.
Yeah. So reaching out to us is terrific, but the answer is you got a lot going on here. It needs specialist level assessment and planning.
You would think that she has a gynecologist if she's had a laparoscopic surgery for.
Yes, and if from that person she can't get a clear plan, then a referral to a reproductive service is the answer. Those guys are all about clear plans.
Yeah. Good. All right. Well, we are thinking of you, and I listened to your speak pipe twice, and both times I cried.
Yes. We hear you, and we're trying to through this podcast. Thank you for the kind things you said about the podcast. We're trying to help people not just with their knowledge base, but also with improve their confidence to reach out to the system, which can be difficult to navigate, and say, I'm the exact person that podcast said I was supposed to get myself sorted out now. Could you help me, please?
Yep. Good. All right, everybody. That's it for this week. We hope you got some little gems from those callers. Thank you for calling in. And currently we need some more speak pipes. So there's a bit of space there if you want to ring through and give us whatever your issue is. We're here to help. All right. Until next week, keep well, keep growing those babies, and we'll see you then.
Thanks for listening, everybody.
Bye for now.
Hey. Even though Dr. Pat is, a doctor, and we get lots of other doctors and other experts on our podcast, I just need to remind you that this podcast is for informational purposes only. We share lots of medical insights and experience, but everything we talk about is general in nature and may not apply to your specific situation. Please always consult with your own healthcare provider for your individual medical advice when you grow your baby.